My name is Rachel Walker, and I'm one of the program coordinators here at the Immunization Partnership. Wanted to say thank you to everybody that joined us today, and thank you for supporting TIP at this year's luncheon. We're very thankful for all of our supporters. We are joined today by Dr. James Leduc and hopefully Dr. Bottazzi. She has not joined the line quite yet, but I know we have a limited time frame. So I'm going to go ahead and read Dr. Leduc's bio, and then if Dr. Bottazzi does end up joining us, we'll just let her jump right in. So to get started, Dr. James Leduc is an expert in infectious diseases, public health, and international biosecurity. He recently retired as the director of the Galveston National Laboratory, one of the world's largest biocontainment laboratories located on the campus of the University of Texas Medical Branch in Galveston. Researchers at the GNL focus on emerging and re-emerging infectious diseases and are involved in both basic research and the development of vaccines, therapeutics, and diagnostics for high consequence pathogens that require maximum containment. He is also a professor in the School of Medicine at UTMB. Prior to joining UTMB, Dr. Leduc worked at the U.S. Centers for Disease Control and Prevention as the director of the Division of Viral and Rickettsial Diseases. He was the Associate Director for Global Health and Coordinator for Pandemic Influenza Preparedness. Prior to the CDC, he was a medical officer in communicable diseases at the World Health Organization and was instrumental in implementing the WHO program in emerging infectious diseases. He was a retired U.S. Army officer who held leadership roles in government research programs and public health initiatives around the world. Dr. Leduc serves on numerous advisory boards and committees, including the Texas Governor's Task Force on Infectious Disease and Emergency Response, the National Science Advisory Board for Biosecurity, the CDC Board of Scientific Counselors, and the National Academies of Science, Engineering, and Medicine's Committee on International Security and Arms Control. So thank you, Dr. Leduc, for joining us today. So far, I do not see Dr. Bottazzi on the line, so we're going to go ahead and let you carry our conversation this morning, Dr. Leduc. For those who joined after I started, my name is Rachel Walker. I'm one of the program coordinators here at TIP. For this morning, feel free to ask any questions to Dr. Leduc, either by using your microphone or the chat. This is meant to be a really informal conversation. And so I'm going to turn it over to Dr. Leduc. We had some questions prepared, but also if you just want to kind of start the conversation and whatever you think is pertinent to be discussed regarding COVID-19 and vaccines.
Yeah. Well, thank you very much, Rachel, and thanks to all of you for joining. Please interrupt or ask questions at will. I really don't have a formal agenda, but I thought I would talk a little bit about variants because that's in the news all the time. Everybody wants to know what's going on with the variants. And we've been very fortunate at UTMB to have, I think, the world's premier laboratory working on this. And let me explain a little bit about how these studies are undertaken. Very early on during the pandemic, you'll recall that China published the sequence of the original virus, but it was very difficult to get access to that virus. And in fact, I don't think we even today have a virus isolate from China. We did, however, receive a virus isolate from the CDC early on from the initial cases that occurred in Washington state over a year ago now. What we were able to do is create what we call an infectious clone. And if you think of this just as a Lego model with a bunch of little parts, they're all stitched together. And we've been able to then replicate exactly in the laboratory the virus so that we can now modify it as new information comes about. So that's an important part. Let me then go ahead and comment a little bit about some of the vaccine trials that we've been involved in, specifically with the Pfizer vaccine. So we have also done neutralization tests on the vaccines that Pfizer has administered. And we've got a set of reference antisera collected from these volunteers. So we use that as our kind of positive control. So using these sera from known immunized individuals and testing it against this virus that we've created in the laboratory, we're able to generate tests that measure the neutralizing antibody. And then going forward, as these new variants have occurred, we've been able to use this laboratory created vaccine or virus to actually engineer in the new mutations and then go back to the same sera and again test for neutralization activity. We've done that now on the UK variant, the South African variants, variants from Brazil. And fortunately, it looks like in all cases, the antibody response is not so significantly diminished that we would guess that there would be a lack of protection. So we have not seen any breakthrough events yet. More recently, there's been some additional variants that have occurred in the news that are of increased concern, and there have been these variants have been associated with breakthrough infections. Rarely, but they have in fact occurred. So again, we're using these same tools in the laboratory to document the reactivity of antibody generated through vaccines to protect against these. And so far, the results are quite promising. So let me stop there because I see Maria has joined us. So I don't want to go on. I wanted to finish that part of the story, Maria, and now please go ahead with your introductions, Rachel and all. Thank you.
Absolutely. Yeah. Thank you, Dr. Bottazzi, for joining us as well. I'm just going to read her bio for everybody real quickly. She is just as impressive as Dr. Leduc. So Maria Elena Bottazzi is Associate Dean of the National School of Tropical Medicine, Professor of Pediatrics, and Co-Director of Texas Children's Center for Vaccine Development at Baylor College of Medicine in Houston, Texas. She is internationally recognized tropical infectious disease vaccinologist and global health advocate with 2 decades pioneering and leading the advancement of a vaccine portfolio from discovery to clinical trials for diseases such as coronavirus, hookworm, schistosomiasis, and Chagas, all neglected diseases that affect disproportionately the world's poorest populations. She has also established innovative partnerships in Latin America, the Middle East, and Southeast Asia. As a global thought leader, she has received national and international highly regarded awards, has more than 150 scientific papers, and participated in more than 250 conferences worldwide. She's a member of the National Academy of Science of Honduras and emerging leader in health and medicine of the National Academy of Medicine in the United States. Dr. Bottazzi currently serves as co-chair of the Vaccines and Therapeutics Task Force of the Lancet Commission on COVID-19. So thank you for joining us today, Dr. Bottazzi. We are just kind of, if you want to open up with whatever you wanted to talk about today, we have a couple of questions. As you see, we were talking about variants.
Yep, absolutely. And first of all, well, thank you for the invitation. Thanks for letting me be in the same Zoom room with Dr. Leduc. I have to honestly say that the work that we have been doing on coronavirus for now more than a decade actually started by a collaborative program that we did with UTMB, with Dr. Ken Tseng and others. And so we really very well complement ourselves. You know, that's the reason why we love, you know, being in Texas at some level with not only the medical center, but having so many impressive, not only institutions, but faculty. So in the area of coronavirus vaccine, our group primarily focuses on actually creating prototypes of vaccines. So we actually do the production side, and then we partner with individuals and groups that complement some of the ecosystem of being able to evaluate them. That maybe the little distinction that we use is, you know, even though we do have programs in RNA vaccines now and many other platforms, but our bread and butter has always been recombinant protein-based technologies using, you know, yeast production, bacteria, insect cell, little, sometimes even mammalian cells, but primarily yeast expressions. And then those proteins are, of course, adjuvanted. And I see that we have Roman here. because Roman representing Dynavax, and I think you're here because you want to hear a little bit our story with the fact that our coronavirus prototype that was transferred in technology, transferred and licensed to Biological E now is partnering with Dynavax to make it a protein with an aluminum adjuvant plus a CpG, which is the Dynavax CpG. And in practically is the same sort of similar platform as the Heplisav, right? Which is a hepatitis B recombinant protein, originally, of course, with alum, and now, of course, it has the Dynavax. So as you can see, it's very traditional technology. And then, of course, like Dr. Leduc said, we certainly preclinically evaluate immunogenicity, efficacy, working with Texas UTMB. They also, of course, evaluate these sera in these pseudoviruses, and now similar to them, we also have pseudoviruses ourselves that we have with all the different variants and mutations. And on a production of our proteins, we now also are re-engineering our, we actually specifically use a little piece of the spike protein. It's the receptor binding domain as our protein candidate. And we now have all sorts of versions of that RBD with all the different iterations of the mutations. But like Dr. Leduc said, fortunately right now, it seems that even the first vaccine, the one we originally transferred to BioE, which is made on the backbone of a wild type receptor binding domain, it seems to be holding up pretty nicely, that the immunogenicity it induces, it seems to still be quite protective against many of these variants. And even though now Biological E will transition into a probably hybrid model where they may have as a secondary vaccine, that comes behind the scenes that is against, I'm going to call it the variant that came up from out of South Africa, because right now that's the one that's being selected. So I'm going to stop there. Pleasure to be open to the discussion.
Thank you. Well, I have a couple questions prepared, but I want the people who joined us today to get their questions answered. So Ricky Graves has a question in the chat for you both. This is more on kind of the policy side of things. When can we expect the COVID vaccines to be approved for kids under 16? Is there a goal to get it done before school starts in the fall? Any insight there?
Certainly what I've heard, the work from both Pfizer and Moderna are very advanced, right? We've already seen some preliminary press releases, I guess, that the data for the 12 to 15 age range is very much advancing very rapidly. I predict that we probably will see a request to the FDA to modify the authorization, and they're going to deploy them pretty quickly. Then the question again is, how will they be rapidly deployed in the structure of delivery? And of course that requires therefore that there's more production to be made. And as you know, there's some concerns about scalability and having enough, not only of course for the US, but eventually, for those who can access these 2 RNA vaccines. Not sure, Dr. Leduc, are you guys doing any of these studies with the 12 to 15-year-old?
I really don't know. The only information I've seen is what everybody's seen on the news. So but I certainly agree that this is clearly an important goal, and boy, everyone hopes that by the time school starts next year that we have the vaccine available, but unfortunately I don't have any additional information. Thank you.
Yep. Maybe what I can make a note is, besides the 12 to 15, which I think probably are going to be the lowest hanging fruit, there are studies already, I think, in the works or already ongoing to look at even below the age of 12 years of age, right? And then the question is, how low do you go? Do you even go to look at the potential of infants, right? Like, to integrate in the expanded immunization programs. And that's still a little controversial, how young kids would need to eventually be vaccinated. I think right now, certainly the school-age children is important, but how low the age. And then I think that, if I may say, there's also how in the acceptance of these vaccine technologies, what's the real tipping point of the parents of accepting these novel technology made vaccines, or in fact, one of our hopes is that when the protein-based vaccines will come into the mix, which we hopefully they'll come soon, with probably in the US initially with Novavax, and globally, certainly we have others like ours, the BioE, and I think there's a Clover, and then there's a Medicago and others, that those things are made with more, again, traditional, like, platforms that pediatrics have used before for any other diseases. Maybe those will allow for a little bit better acceptance, especially if you are going to use them for very young kids. So we'll have to see how that goes.
One other comment. I don't recall exactly the reference, but I think that there's been some data come out now of pregnant women that have been immunized, perhaps inadvertently, but looking then at follow-up through pregnancy and the outcome with infants, and no red flags that I'm aware of. So I think kind of at both ends of the spectrum, it looks very positive. So I would hope that by the time school starts in the fall, that there's sufficient data and access to vaccine that it'll be available.
Yes, definitely. Well, and everybody feel free to ask questions in the chat or using your microphone if you have them. I wanted to kind of switch gears a little bit because I know, Dr. Bottazzi, you have a particularly international focus in your work. And so I wondered if you could speak, briefly about how the US is doing with our rollout of vaccines, and then how that compares internationally. And if you are concerned about any particular regions or countries when it comes to vaccine access.
Yes, and I have to say, as much as we would have hoped that we would have equity and social justice on some level, not only in vaccines, but in many areas of this COVID-19 pandemic, it has not really happened as we wished we could. That doesn't mean that we haven't had some really really good attempts and even programs. As you know, the intent of the COVAX, which was this framework of how to ensure that we could organize better this deployment and access of the vaccines. And complement to COVAX is the whole, what we call the ACT pillars of the World Health Organization, and CEPI and Gavi and WHO, and which unfortunately I have to say, in the prior US administration we were not participatory, and so I have to say it was a shame, because the US totally was not seated at that governance and leadership table, and that, I have to say, probably made a huge disadvantage of enabling these initiatives. Now it's changing, a little late, but certainly, we could arguably say it's really never ever too late, but it's late. And so that it's a big concern. So the privilege that we have in the US, albeit I can say, yes, we had struggles, it's complicated, but albeit at least we have a couple of things. We have vaccines, and not even one, we have at least 3, if you consider J&J eventually will be resumed. Probably we're going to have even more. We're going to have 4, with ample capacity of even making our own lots, and certainly money to have procured them and invested even in their development. Compared to COVAX, which ideally had issues even fundraising, and if you compare the billions that the government of US invested versus the little bit that even globally the COVAX was able to fundraise, it's ridiculous in my mind. And the fact that there's just no production, and that right now the only really availability for everywhere else around the world is that not many countries cannot adopt Pfizer or Moderna due to the challenges of the cold chain and the cost and maybe the availability. So you're only left with today AstraZeneca and theoretically J&J, and they already have a lot of communication, not good communication practices, so people are quite hesitant maybe, or they don't understand them. They don't understand still the benefit versus the risk. So we have a huge problem, because even if the US, we can go with very nicely now, it's very open, but just next door to us and the rest of the world, we have nothing. I mean, literally nothing. And the little bit that we may have, it's even not being communicated in a way that people are really accepting that because, you know, there's a lot of misinformation out there. So we really need to do something very quick. So technically, there's many things we can do to solve this, right? Money, I think, exists, except that, you know, money has to just be deployed. And I know there's enormous efforts through the World Bank and all the agencies at creating these systems of the monetary fund piece. And I think that can be solved. But we still have to deal with people accepting the use of vaccines. And I think that's the real reason why maybe this second tranche that are going to be coming out soon, including this bunch of protein-based type of vaccines, which are much easier to be made. There's much more ecosystem. They're cheaper, and they already have a precedent, even subliminally, of safety, that then we can really use them to ramp up.
Let me just add a couple of comments. In addition to the vaccines that we are very much aware of here in the United States, some of the early data on the Russian vaccine seems that may be quite efficacious as well. So there are potential other manufacturers. I was pleased to see the information now coming out of China, recognizing that their initial vaccine, which they promised to many parts of the world, really isn't as efficacious as one would hope. So it's good that they're admitting there's a challenge there. And in fact, they have tremendous resources and in fact are going back and looking at alternate strategies. So I think globally, this is good news. You know, this is a brand new disease, brand new technology, and literally the entire world is susceptible. So this is a problem that the entire world needs to engage in. So I'm cautiously optimistic that over time, but we're talking years, we're not talking about the next week or this summer, that there's going to be sufficient vaccine, but it's going to be a long, long haul. So.
Yes, and on that note, you're absolutely right. And this actually was a great opportunity of inviting and actually allowing groups like Russia, like China, to work more transparently and integrate better into these global efforts, like, for example, the WHO pre-qualification processes. And I have to say that it probably hasn't been easy for them. I know they have been actively working to ensure that they have utmost quality and certainly standards. Not that they don't, but it's never been really well recognized, you know, because sometimes they're not really working through those, let's say, checks and balances. And now they are. It's still difficult. Like, for example, you know, you may ask, for example, why we see reporting on the AstraZeneca, reporting on the J&J, with regards to, of course, these not only now very rare adverse events, but albeit, you know, the fact that they have been really being recognized because of the pharmacovigilance systems, right? That, you know, especially the countries like US have, like Europe has. And so we are really now, that the other side of the coin is, you know, if we know now that the Russians and the Chinese are really working to strive to ensure good quality and transparency, we also need to reinforce the regulatory and the pharmacovigilance, right? Because it may be that smaller countries or regions don't have the same strength in their reporting, and that's why we are not very clear of what's happening when you deploy these vaccines so widely. So that's very important, right? Because if we are able to recognize any other issues, and it may not be that the Sputnik vaccine have the same concerns as the J&J or AstraZeneca may have had with these clotting events, even though I have to say there's been some identified even in Pfizer and Moderna, but they are so rare that I think, like the key here is that you have to have a system, a regulatory system, a means of investigating, a means to following up, and then creating these benefit risk ratios, right? And determining what is the probability and why you have to maybe eventually put some clear directives of how to manage them, right? Because I think they're manageable, and not letting them go out into the media without really having a risk communication strategy where you really communicate well. Because people, when they hear this, the only thing they hear is that, oh my God, I'm gonna die with this. They don't realize that it's still such a low, rare event that they're likely gonna probably die faster in a car accident or even, the probabilities, there's so many probabilities, right? So what is an absolute probability versus giving these messages that are really not very clear? So.
Absolutely. We have a couple more minutes, so I just wanted to encourage anyone who hasn't asked a question yet to feel free to do so. Otherwise, I think our speakers, you guys are on a real roll, so I don't want to interrupt you, but if anybody has a question, anything burning related to the COVID-19 vaccines, you have two incredible experts right here. So feel free to ask them.
Do you have any insights or opinions on the recent news about a possible booster shot? I know that just came out maybe yesterday or the day before.
Let me make a couple of comments. In my comments earlier, I said that we have been looking at the immune response to all these variants and all, and we've been working very closely with Pfizer going forward. Moderna published the results of 6 months follow-up fairly recently, and it looks, as you would expect, antibody titers are declining, but they're not to a level where we suspect that it would impact susceptibility too much. One would hope, and I think the evidence supports the fact that the vaccine remains protective at least through 6 months. Pfizer has not published their similar data, but without divulging any secrets, I would not be surprised, I guess, to say that they're seeing exactly the same pattern. My guess is that should boosters be required, it will be sometime around 1 year post the second shot for a booster. And after that, my guess, unless there's a major change in the antigenicity of the circulating virus through a mutation or something, that's probably where it's going to end. But that's just my own personal speculation. So I would expect some greater talk about boosters sometime in the fall or towards the start of next year. I do know that there are clinical trials already. I don't know if they've started or not, but I know they're being discussed to actually look at boosters now from those that participated in the initial phase 3 trials going forward. So I wouldn't be surprised, and I expect that unless there's a real significant emergence of a variant, that the booster will be the same vaccine that we've had before. And that's partially because of the regulatory issues of really changing a vaccine too significantly. So Maria may have other comments as well, but that's my thought.
Yeah, I totally agree with you. And of course, it also will depend on vaccine versus other vaccine, right? So we definitely know that there is a spectrum of these efficacy rates, and then we'll actually have to keep track of the the effectivity of it, once it's mass distributed, in the context of how much the virus circulating is going to eventually go down, right? To see also how quickly they're going to mutate or attack rate. So it's probably going to be dependent on, again, for example, maybe indeed if one of these whole inactivated virus vaccines don't confer as, you know, highly protective immunity, maybe those need to be boosted. Maybe the adenoviruses, because, you know, if you need to boost too close, you may not be able to boost with its own. You're probably going to have to use a protein-based vaccines. But for the most part, what we've seen certainly from the RNA technologies, it may be less urgent from the RNA vaccines as of today. But it really will depend also how quickly we can get rid of this circulating virus, right? And see what happens. But we need to be prepared, certainly. And I do know, like, for example, Biological E is considering preparing and, for example, extending and re-consenting some of their phase 2 cohort volunteers to potentially say, can you come back and we can boost you? And, you know, so they're kind of doing these very innovative clinical trial designs to also don't lose the opportunity of those who already had received a few, and see what happens if you use other vaccines.
Thank you both. So we are butting up against the end of the call, and I put the link to the virtual program for the luncheon into the chat so you all can get it really quickly there. We did have one final question, which I think is the perfect question to end on. So if either of you can summarize, you know, kind of your elevator pitch to how any person, whether you're scientific, lay person, can communicate to someone who may still be hesitant about getting the vaccine. What would you tell them? I think that's a great way to end today's conversation.
Well, I would say tell your story, right? So tell why, you know, make it personal, right? You know, like why you got the vaccine, why, you know, you think that you certainly trust the way that it was developed and, you know, eventually came about, the fact that there's years of work on coronavirus research, right? Even though this is a new virus, fortunately came from a family that we already knew existed, right? You know, that is not something new. And just, I think, make it personal. And the last thing maybe is listen, right? Because, you know, you can make it personal, but you have to also hear what it's personal for the other side and why they are not very amenable to vaccinate themselves.
Boy, I agree with all of those comments. And really, this is a very significant issue. And I think the more that the general public can weigh in, and as Maria said, tell your own story. And not only the fact that you've received the vaccine and you are fine, you don't have 3 eyes or anything, but also I think the responsibility as a member of society to protect others from this infection. But you know, browbeating people isn't going to work, and unfortunately, the whole vaccination issue has taken on some political baggage that really has not been helpful at all. So I think just being persistent, but not confrontational, I guess. And you know, people make decisions for a lot of different reasons, and you know, we all know that smoking's not good for you, but a whole lot of people still smoke. So you know, sometimes you just have to say, all right, it's your choice, but this is why I'm doing it. Thank you.
Well, again, thank you both for giving us your expertise today. You were wonderful. Thank you to everybody who joined us, and thank you for supporting TIP. Your support means more than ever.